Hello, everyone. Welcome to another episode. I'm Bodine Ledden, joined by Shaun Brewster. And today we're going to be talking all about a very hot topic in dry needling and something that people tend to have a lot of fear associated with, and for good reason. But we're going to explore this topic a little bit more, and that is the topic of pneumothorax. Shaun, where do we start with this topic?
Well, I guess when it comes to, I guess from our experience, we talk about dry needling in the classroom a lot with students and trying to train them to be effective and safe in this modality. And you can't do that without discussing and exploring adverse events, the potential adverse effects of dry needling, things that could go wrong. And we always explore those from, the low, moderate adverse events right up to the more severe ones. And invariably, we get towards that top end of the severe ones, and pneumothorax is at the top of the list, right? It's the scary one. We puncture the lung or the sac around the lung, and then the person goes off to hospital. And I've met some people and spoken to some people over my career who have inadvertently caused a pneumothorax for a patient, and it can really shake them to their core, and their confidence takes a hit. And I've had people that have been very close to leaving the profession because of this sense of guilt and ownership over that injury. And every case I can think of, the patient's recovered just fine. It's not that that's the issue. It's the stress, and the fear of injuring somebody when you're trying to do something good for them. And that's understandable. I think we can understand people going through that thought process. But realistically, it should be a very easy injury to avoid. We do see in some cases spontaneous pneumothorax unrelated to needling, of course, which we'll explore both of those types today. But it shouldn't be something that happens clinically when our understanding of anatomy and our application of needling is done in a safe and effective way.
Yeah, that's right. And it's often something that people do come into these courses with a lot of nerves and apprehension and worry and fear that's associated with putting a needle into someone else's body. And yeah, absolutely with good reason. I think that's important to understand that it certainly is a risk factor, but as we often emphasize, it's really about understanding your anatomy and you know using your anatomical knowledge to sort of appreciate the depth of tissue that we've got to work with, the angle of the needling, the different layers that will pass through, the size of the needle, the size of the body, the cross-sectional area of the muscle mass, and all of these factors that can come into it. And, when we look at dry needling in general, it is a very safe modality, provided that it is applied appropriately. And we see some crazy approaches out there, and you think, wow, that's surely not safe at all. And so I think it's going back to basic clinical reasoning and understanding what you're trying to achieve and the safest approach. That's really important when we consider dry needling, particularly around the thorax area.
And I think probably a good place to start for those who maybe aren't familiar or maybe even know about pneumothorax but aren't fully understanding what it is and why it happens. Well, let's start with a bit of a definition. What is pneumothorax from a physiological point of view? We've got our lung, and then we've got the cavity around the lung, the parietal pleura. The space between those two things has a negative pressure in it for the lung to be able to expand and contract within that safely. And if something were to pass through the parietal pleura and create a positive pressure, then that internal pressure becomes too great and it can compress and essentially collapse part of the lung. And I think that's key to highlight as well. It's very rare. You'd have to have a very severe pneumothorax to collapse an entire lung or even both of those lungs. It's a part or a lobe of that lung that gets collapsed. And that's why people can still breathe with a pneumothorax, but it becomes very difficult for them.
Yeah, exactly. And so when we think about respiration in general, we've got, at rest, there would be equal pressure within the thoracic cavity versus in the atmosphere. And then you've got your parietal pleura and your visceral pleura. So your parietal pleura essentially holds the ribs to the thoracic wall. And then we've got the visceral pleura, which sort of covers around the lungs. And so in between that space, as you said, that's where we've got this negative pressure, and it's about -4 millimeters of mercury. And so Think about that though. We've got a fluid in between those, the visceral and the parietal pleura, and that fluid essentially reduces friction during respiration. But if something passes through that parietal pleura, that changes that pressure. And so what happens? Well, because when we breathe, we've got the muscular force, and then we've got that elastic recoil, and so it's sort of, because we've got that fluid together, it's a little bit like if you can picture a glass cutting board on a bench top with a thin film of water underneath. It can be very difficult to lift that off. So they sort of stick each other together. But when there's that pressure change, now there's there's a loss of that seal. And like you said, that sort of there's a change then in the elastic pressure, the elastic recoil versus the muscular force, and the visceral pleura will move away from the parietal pleura and the ribs. And so essentially, yeah, by definition, that's essentially what's going on when we talk about a pneumothorax or a collapsed lung.
That's right. And the symptoms we see can often be misleading too, because the patient may receive a iatrogenic or medically induced pneumothorax, and it's several hours typically, isn't it, before they feel symptoms. It can take quite a while. So the patient goes home, goes about their day, and then suddenly, several hours later that day, maybe even the next morning, they notice some symptoms. And it won't always be linked back to the needling, acupuncture or dry needling. And it can be quite confusing and probably quite confronting for the patient in situations like that. And so what our obligation as practitioners is to identify those symptoms, to really know what they look like and be able to effectively manage it. And I think that's where we get a lot of confidence from situations like this, is knowing what things are, knowing how to respond appropriately, and then being able and willing to take those actions when required. It's when people don't understand something and don't know what to do when it presents, that's when fear becomes more of a factor. So that's what we're trying to address today.
Yeah, certainly. And so what would be some symptoms that we might typically see in a patient that presents with the pneumothorax?
I think medically there's a lot of different symptoms that can present, but if we're talking purely, at least in the beginning, from what does the patient complain of, it's going to be a shortness of breath. They'll often say things like, I have a weight on my chest, like imagine someone standing or pressing on your chest, difficult to breathe in, typically to get a full breath in. They might be able to breathe out, because obviously that's a squashing of the lung, but to breathe in, we need to expand it. That's where we have the difficulty. And often fatigue. The patient present like, I went for a walk with my dog and got back and I was just really breathless, and I was short of breath and I was kind of tired. And so those are typically the subjective feedback that we get from the patient if they were to call us up later in the day and say, hey, what's going on here? But we can have other things. We can have pseudomotor activity. We can have increase in sweating. We can have increase in heart rate. Obviously, increase in respiratory rate. We've got a lack of oxygen. And so we want to breathe more and breathe faster. And that can present itself with lack of color in the extremities, maybe the lips, fingertips, extremities, things like that can be a little blue. So cyanosis, there's a whole range of different things. And being able to identify those things in conversation is the tricky part, right? Because it's often hours later. So the patient's going to call you and say, hey, I've got some stuff going on here. Any indication what that might be? So being able to ask those questions and look for those things over the phone, right, is the challenging thing, because we can't see the patient.
Yeah, definitely. And so let's say, for example, a patient was presenting with some abnormal signs that you think this doesn't quite sound right. What should be the process that clinicians should take?
Well, this is obviously, Bo, this is what we prescribe or recommend in our courses. And there's two components to this for me, which is, one is there's the human caring component that we should put first and foremost. And then there's the medico-legal ethical component. And you can't separate the two, and we shouldn't separate the two. If we just follow the legal reasons, the legal reasons for doing things, and we forget the fact that we've got a human in front of us, that can often lead to different outcomes. And so first and foremost, let's just play this out in a scenario. So the patient phones us up later in the day and says, hey, I'm just calling to let you know I'm a little bit short of breath, and I don't know what's going on here. I know that you needled my back earlier today and you said it'll all be fine, but is there a chance something's gone wrong? And so first and foremost, we want to not alarm the patient, because if they're in a state where their respiratory system's been negatively affected, they may have a pneumothorax. Their heart rate's probably a little higher, their breathing rate's higher, and we suddenly turn around and say something like, oh, this sounds like you've got a pneumothorax, which is a collapsed lung. We need to get you to hospital. That's only going to negatively impact their current physiological state. So we need to be fairly clear about the risks associated with what may be happening. I think we need to tell them the truth, of course, and say, okay, the symptoms sound a little bit like a pneumothorax. So I think without being too alarmed at this point, we need to get you off to the hospital as safely and as efficiently as possible, just to be sure. Now, even if it is a pneumothorax, there's a very good chance it's going to resolve itself fairly quickly, but let's be certain. Let's not leave anything to chance here. Do you have anyone with you who could drive you to the hospital? If not, let's get you in an ambulance just to be sure, because if your symptoms get worse and you're driving yourself, there's an obvious risk to you and people around you. So off to hospital would be the first step. When they're on their way, I always think it's a good idea to, especially if they're being driven there by, a spouse or somebody at home, to encourage either them to do this or you do it yourself. Call the hospital head and say, hey, we've got a suspected pneumothorax coming in. I personally have been and sat in waiting rooms and emergency rooms in hospitals for hours and hours and hours before you get seen. In fact, sometimes so long that they just send you home. And so if you walk in there saying, hey, I'm just a little bit short of breath, don't know what it is, they probably go, oh, this guy's got the flu or something, sit down, we'll see you in about 9 hours. So phone the hospital, tell them there's a potential pneumothorax coming in, and they should get triaged right through immediately. So that's taking care of the person, right? That's putting the patient first, making sure they're getting the care they need and as efficiently as possible. Then we come to the medical legal requirements for us. We go back to the patient notes. We've seen them that day, yesterday, whenever it was. We should note down that we received a phone call or however they communicated with us. We write down in their patient file the symptoms that they presented with over that call or how we spoke to them. Write down the time and the date, and then note that that it was you that made that amendment to the patient file. Then I think it would be a really good idea also to follow up with the patient. Several hours may have gone by, maybe it's the next day. I think, again, coming back to the human side, it's best to reach out to that patient and check in on them. Show them that you care. Show them that you're following up. They are your patient. They have been in your care, and they should continue to be in your care until that relationship ends. So we want to make sure that they're okay and that we are showing some concern for their well-being. There is a fine line, though, Bo. Here's the tricky bit, right? So if you speak to an insurance company about incidents where you may have caused an injury or potentially caused an injury to a patient, their advice is always never to admit fault. And so if you call the patient up the next day and say, hey, look, I'm really sorry that you're in there at the hospital dealing with this at the moment. Look, I don't know what I did, but I must have made a mistake, or I'm really sorry that I caused that. That's an admission of guilt. Now, there are, as we'll explore soon, there are a lot of reasons why someone could potentially end up with a pneumothorax. The chance of it happening from needling is actually quite low, especially when you're doing it with a skilled practitioner. And so an admission of guilt can dramatically change the outcome if something like this came to a medical claim or into a court case. And so we should never say, I'm sorry, or I'm at fault. We can show concern and we can show interest in the welfare of the patient, of course. And I've, in my experience, having spoken to people who have almost definitely caused a pneumothorax for their patient, when they've done that, in almost every situation, that's resulted in the patient coming back to see that practitioner again in the future. And so there's no guilt weighing over the top of the practitioner. There's no feelings of hard feelings or anything like that from the patient, because they've felt like they were cared for. I think that's really important from a human point of view.
Yeah, that's some really good advice there, Shaun. Well, let's talk about that then. Let's talk about how common are pneumothorax? What's the incidence that's associated with dry needling?
Well, I guess we want to differentiate here because we've got spontaneous pneumothorax, which can just happen to someone that's not caused by, intervention from a medical practitioner. What's what we mean by spontaneous? There's some other physiological factor at play. And then you've got iatrogenic pneumothorax, which is we've done something. Now, sometimes that's from a needle, but sometimes it can be from, a stack of other things that would happen in a more medical or hospital-based setting. So if we look at the incidence in Australia of spontaneous pneumothorax, that's like about 10,000 spontaneous pneumothorax, more than 10,000 spontaneous pneumothoraxes happen a year in Australia alone. So obviously you take that population, 35, 40 million people, multiply that for, say, like the US, where you've got 300 million people, you would assume that number goes up in relation to the size of the population. So that's a lot of people presenting with pneumothorax. Now, there's a lot of factors that can contribute to that. And if someone came to see you or I, Bo, for some dry needling, and then went off to a hospital and just happened to have a spontaneous pneumothorax, it would be reasonable to point the finger back to us and say, hey, it's probably from that needle you stuck in my back. But in actual fact, the incidence of iatrogenic or doctor, medical, health practitioner caused pneumothorax is really, really low. So we're talking about 5 out of every 10,000 hospital admissions for pneumothorax. It's a really small number. There was a few different studies done on this on different cohort sizes around the world, and one of them quoted something like 1 in 380,000 incidents of dry needling, so applications for dry needling, resulted in pneumothorax. Another one showed 1 in 1.7 million dry needling applications, or acupuncture, I think in this particular study, resulted in pneumothorax. And another one showed 1 in 1.3 million incidents. I think that's right. 1.3 million incidents of dry needling resulted in pneumothorax. So we're talking really, really big numbers. So if we take a snapshot of everybody that's receiving needling, whether that's acupuncture or dry needling, the chances of it resulting in a pneumothorax is incredibly low. And then if we look at the people receiving a pneumothorax, the chances of it being from the needle versus something else is again very, very low.
Yeah, that's some interesting stats there. And, again, we look back to then level of training of the practitioner, level of understanding of an anatomy, needling experience, all of that sort of stuff can factor into it. So I guess, we understand that it is pretty low incidence. It's in fact very rare. But what might be some higher risk muscles?
Yeah, right. And look, I'll give you my experience from someone who, like yourself, have taught dry needling for a really long time, and often you'll get phone calls from someone who goes, "Oh, you've been teaching dry needling. I think I may have caused a pneumothorax, or my friend caused it, or someone had caused it. Here's the thing that happened, right? Here's the needling application they did." And so you kind of hear it on the grapevine just by being in space. It's classically shoulder, so upper back shoulder, so upper trapezius, left scap. So we're talking the upper dome of the lung, sort of closer to the neck, and then often along the thoracic spine in the paraspinal region. So someone's trying to needle an erector spinae muscle and has it inserted the needle too wide or at too great of an angle. But when we're up around the shoulders, again, it's the upper trapezius, left scap, and they're not needling in a direction that's appropriate. They're needling towards the rib cage. And I think if we go back probably 15, 20 years, a lot of the needling applications around the thorax people were using this bracketing technique. They'll place the fingers between the ribs, aim the needle towards the rib, using the rib as a bony backboard to keep them safe and out of the pleural space. But that relies on one margin for error. There's a classic video on YouTube that shows somebody teaching that technique, and they go, here's how you aim for the rib, and they miss the rib in the video and cause a pneumothorax. So it's that simple. And so regardless of your skill as a clinician, as a dry needler, then if you've only got one step or one thing that could go wrong and it results in the problem, that's not enough margin for error for me. We need to build in some other layers of protection.
Yeah, that's important, isn't it? And we think about a rib, we know that the ribs aren't completely flat either. They're sort of rounded. The needles are very bendy. There's also several layers of tissue between our fingers. So we can't be 100% certain that is the most effective approach. And again, like when we talk about some basic things to mitigate risk, palpate the tissue for one. How much tissue do you have to work with there? And then you can make a pretty well-educated guess about what your margin for error is. How do we mitigate that by then angling the needle? And then what if let's use the appropriate size needle. Let's use a smaller needle on a smaller body, or in an area that's a higher risk. So then if you do happen to go in an angle that may be not quite right, well, you'd run out of needle before going too deep, ideally. And so there's several things you can do to mitigate risk. But I guess, we often get questions at dry needling courses, about pneumothorax and certain high-risk areas, and questions that might be, oh, what about this muscle? Could you needle this muscle? And one that always gets me is, oh, can you needle intercostals? And I just
Yeah, it's a great
go,
one.
I can't think of any clinically reasoned explanation as to why I would choose dry needling for an intercostal muscle when we consider the risk versus reward. You know,
Yeah.
like things like that. And you've got to look at your tools that you've got as a clinician and think what would serve the most benefit, that would do no harm. Okay, and I think that's important. Like intercostals, like serratus anterior, scalenes, these types of muscles. That I mean, you just got to look at it and think, you know what? I could do another technique that would serve just as good value with far less risk.
And my favorite one of all time is I've been asked probably more than once actually, can you needle the diaphragm?
Diaphragm, yeah, classic.
Well, yes, you can needle the diaphragm, but please don't do it on me because I'm going to go to hospital if you do that. Yeah,
What
there's a
does the
very good.
diaphragm do? Well, as it contracts, it pulls down, it increases the pressure in the thoracic cavity. So it's a very important muscle of respiration. I mean,
Yeah,
how close do you want
and
to get?
also to your point about the intercostals and I guess diaphragm as well, to even to a greater degree, they move, right? Unless you've got a patient holding their breath, we insert that needle and that tissue is moving quite a bit while the needle's in the tissue, uh, and that's probably not ideal. Not ideal when we're trying to avoid getting the tip of that needle into the pleural space. So yeah, absolutely. But look, you talked a moment before about needle size and palpation and stuff, and then we've got to have different types of patients, is right? Different sizes and different morphology that we see, tissue thicknesses. We often get these questions and comments about, oh, I've got this patient at home I think is going to really benefit from it, but they weigh 180 kilos. You know, like we've got a morbidly obese person. They've always got trigger points or whatever they, might be quoting in their body wherever they are. And I really want to do dry needling, but I'm not sure I'll be able to get deep enough. What do you say to that?
Yeah, well, I mean, it's a good question. You've always got to weigh up again risk versus reward. Can you
Mm.
safely and accurately get to the level of the tissue and know exactly where you are within the tissue? Because we've got to go through, depends on the area, but it may be several centimeters of uh, adipose tissue. So can you get through that and still be able to accurately understand how large that muscle is and where that needle is within the tissue? And if you can't do that, then don't needle them. Um, but in some areas that you could safely do that, and you might think, all right, well, if the needle goes too far, what would I hit? Well, I might hit a bony backboard, or I wouldn't be at any risk of going into any underlying neurovascular structures. Then you might be able to make that clinically reasoned judgment where, as you pass through those initial layers, you would feel the change in resistance through the subcutaneous tissue and then into that fascial boundary. But again, yeah, it's always going to come back to what would happen if I went too far, or what would be the increased risk of going too far. And so if that risk outweighs the benefit, then choose something else.
100%. And it's really common sense, isn't it, when you're talking about it? And I think this is where practitioners fall into their own trap is they go, like, I'm really good at dry needling. I want to do dry needling. I get good results at dry needling. And the patient becomes less of a decision-making factor in that than their bias towards the modality. As they go, I get great results with this. So no matter who walks in the door, I'm going to use this. And you have to put the patient in front of you first before you make decisions about what you're going to do. And this is a classic example of that, I think. Let's take a step back to that spontaneous pneumothorax just briefly, because I think that's an important one to explore as well. And like we saw before, like 10,000 plus incidents, even just in Australia, presenting to hospital. Now, there's going to be a lot of people who get a spot or, experience a pneumothorax, either spontaneous or not, that don't present to hospital. So there are a lot of these happening, right? There's a lot of people suffering from pneumothorax in our population. Some of the things that you might think can contribute to a spontaneous pneumothorax. What do you reckon?
Well, being tall. So I think I'm
Yes,
in the clear, I'm medium size.
you're
uh,
right. And in fact, being male and tall is even
Female
more a higher risk. Yeah,
and skinny, very skinny.
absolutely. Tall, thin males, and in fact, 20 to 30 years of age, so younger, and I'd probably even cluster older teen years as well into that one as well. tall, thin males, very lean build. And then we go into other things like smoking is going to be a contributing factor. Funnily enough, pregnancy increases the risk of spontaneous pneumothorax as well. Marfan syndrome is another one. So people that have Marfan syndrome. And then we have familial pneumothorax, which is people who have a family history. Now, here's an interesting thing I discovered recently. If you have had a spontaneous pneumothorax, the likelihood that you'll have another one dramatically after that first one improves over time, but in the first 3 to 4 months, it's something like 35% chance that you'll get another one. And at sort of 6 months, it's like, a smaller number, and we just progressively go out over time, but 30 to 50% chance on average, if you've had it before, you'll get it again in coming months. And so that's something to be aware of. But interesting, I think the thing I found most interesting about this is that if you've had an iatrogenic pneumothorax, let's just say needle-induced, it does not at all increase your chance of receiving another pneumothorax afterwards. It's only if it's come on for more physiological or morphological reasons.
Yeah, and so I think let's explore the spontaneous pneumothorax. And from my understanding, sort of what happens is there's I guess a bursting of the alveoli, which forms a bleb on the surface of the lung, and that bleb can burst, and that sort of causes a rupture in the lining of the in the pleural space, and that's where the pressure difference occurs. So obviously in tall, skinny males of a younger age, then and holding their breath, that can increase the pressure and increase the risk of those blebs bursting, and that could be very, very similar in people with who are smokers and emphysema and conditions like that, where that can cause a rupture of those air blebs and result in the spontaneous pneumothorax.
Yeah, absolutely. So there's a lot of things at play there, isn't there? We have to consider not just those ones that you're talking about there, those unusual physiological causes, and then the needle-induced ones, but then there's trauma-based ones. Someone has a car accident, fractures a rib, there's a crush injury of some sort, and so it can be an external or an internal input, which is sort of that third category. It's not necessarily something to do with what's going on in your body. It's something that's happened to your body, but it wasn't from something medical induced. And so there's a range of different reasons why somebody might end up with a pneumothorax.
Yeah, high impact sports, martial arts, football, all receiving trauma around the thoracic cage. That could certainly be a reason for pneumothorax as well. But I guess obviously that history would be important when we're considering this in a clinical setting as well.
Yeah, definitely. And look, I just want to touch on one last thing, which is coming back to that medico-legal requirement. One thing I didn't mention before after, taking the notes is that if you ever did unfortunately find yourself in a situation where you had to go to court, the patient was maybe suing for medical costs or suing for injury or whatever it might be, the key thing that is going to protect you as a health practitioner is thorough and effective note-taking. And so recording what you do in your consultations with your patient, and then anything that happens after that, after the incident that you've recorded and noted down, any contact with the patient afterwards, it should all go into that history, into that clinical note-taking document to document all of that. And that, interestingly, as someone who's acted as an expert witness in court cases for things like this before, those documents are seen as gospel. They're taken as truth. And so whatever the patient writes down, even though it's them writing it down, it's not the patient's contributed to that. Whatever the therapist writes down is submitted to the court as evidence, and it's held in high regard. And so if you've got a history of taking really good, thorough notes on your patient consultations, that's even more evidence that what you've written is true and correct and factual. So can't emphasize this enough. Write down what you do in your consultations. Write down what happens if something goes wrong. Don't hide from the facts. And if you do get contacted by a patient that has, maybe made a claim that the needling's caused an injury or even, alluded to it, it's also a good idea to contact your insurer ahead of time. Insurance companies, and I've again dealt with a few of these over the years, insurance companies will be on your side if you're on your front foot, not your back foot. And so coming to them saying, hey, here's what's happened. I don't know if it was me or if it was something else, but I just want to let you know. And they'll say, great, write us a report of what happened, maybe submit your patient notes. And their job is to support you at that time. But if you're hiding from it, saying it wasn't me, and coming to them at the last minute, that looks guilty. And insurance companies are in the business of making money, not spending. So if they can find a way to not, that might occur.
Yeah, that's such good advice, isn't it? And when we consider how important it is to document and document thoroughly, and this all comes back to stuff that we emphasize to clinicians is that, you know, when we talk about understanding your anatomy, be accurate with your terminology. Because if you're not accurate with your terminology in a clinical setting among other clinicians, you know, are you going to be accurate in your note taking and documenting? And we know that it's very rare for this for a pneumothorax to occur, but if in the off chance that it did happen, then you are going to protect yourself. You can go back and, you know, you might have seen 40 patients that week or more, and you go back, oh, that's right, John Smith, that's what I did. Yep. Clear in my mind now. I know exactly what that consultation was about and exactly the needling approach that I did and my reasoning for that. And that is all important because when we think about putting all of that together, you can rationalize what you're doing. Don't just go putting needles in just for the sake of doing it. There should be a rationalized, clinically reasoned explanation as to why you're doing it. But, you know, yeah, that thorough documentation will really protect you in the long run.
Standard. I think you hit the nail on the head when you said that using clear and appropriate medical terminology is important, because you can imagine if you did find yourself in a court case or something and someone else is going through your patient notes and they say, Bo, on that day you said that you put a needle in their shoulder, you know, or in their upper back. It's so vague. And then you turn around and say, oh, no, it was this, this, and this. If your patient notes have a history or have a track record of being accurate and precise and detailed, and then you say, I did this, that's much easier to believe. You know, there's evidence that this person is accurate and precise and detailed in the way that they work. And so your patient notes should be a reflection of how you think and work as a clinician. And ideally, it should be quite detailed.
Yeah, that's important, isn't it? Shaun, is there anything else that we should be discussing here? I mean, I guess we spoke about, I sort of touched on don't put a needle in unless you've got a clinically reasoned explanation. I mean, we often see this on social media, on the internet, that there is just needles everywhere, or they're very symmetrical. Like, what do you think about this?
I think this is a bugbear of mine, and I know it is of yours as well, which is where people are clinically reasoning their treatment processes or applications based on how it looks in a photograph. You know, they've got 3 needles across the upper traps, 2 in each rhomboid. They've got 1 in each left scap. It's laid out perfectly because it looks nice on an Instagram photo. This is not, again, this is not putting the patient at the center of your decision-making process around their care. I can't think of the last time that my treatment looks symmetrical on a patient, because people come in and they're just not symmetrical. You know, there's a problem on one side here and on the left side over there and another side over here. And the treatment should look, if you're doing needling, it should look appropriate to the presentation. And the presentation is going to be guided by a whole bunch of things around palpation and physical assessment and subjective and objective measures. There's a lot of things to consider. So if you're making decisions on what looks nice in a photo, or worse yet, here's how I treat this region. Like, I have shoulder problems, I do this. For lower back, I do this. For hips, I do this. Then that's not a patient-centered approach to care. And I think that's where people get unstuck. They almost switch their brain off and go into a protocol-based approach, like, oh yeah, I know what to do for your kind of problem, versus I know what to do for you as an individual.
Yeah, and that's the funny thing, isn't it? When we see sort of, I guess, approaches that this is how you needle this muscle and don't do it any other way, or this is where you find the trigger point in this muscle. And so we always emphasize understanding your anatomy, know the cross-sectional area, sort of like you are the eye of the needle. What are you passing through? How many layers do you need to get through? Where are those major neurovascular structures and organ cavities that you need to be considered of? And how would you direct a needle in a way that would avoid all of those structures and be safe and effective? And so that's where we've really got to understand and appreciate three-dimensional anatomy, because if we go back to getting the best results or most optimal results for clinically, you know, and we're talking about trigger point dry needling, ideally, we would palpate the most tender spot that reproduces the familiar symptoms and aim to needle that tender spot directly. And so that may not match exactly where that X on the chart is. So it's got to match into your patient presentation. So you've got to understand your anatomy enough to know that, okay, if this is where I'm going to needle, what's the angle that I should take? What do I need to be considerate of? How big's this person? What size needle am I going to use? And then feel through those layers of resistance. And that's how you can be safe and effective with your needling approach, and not just needle it because this is the way that I sort of learned to put it in, and that's that's where the trigger point chart told me to put it in. So that's how I'm going to do it, or that's how it looks pretty on an image. So
That's right. And you do all those things. If you can use that level of clinical reasoning to make your decisions about how and where you'll needle, then you can get a lot of confidence from that. It's like, I've actually thought this through. I've considered the patient. I've considered my skill. I've considered the structures I'm working with, the needle size, all of those things. So when the needle goes in, you have a degree of confidence about what you're doing and why you're doing it. Then the chance of injuries are zip. They're very, very close to zero. Obviously, there's always some allowance for anatomical variation that we need to be considerate of, and that's why we sometimes get bleeds and bruises and nerve stingers and bits and pieces that we might get when we're needling somebody that we wouldn't get on someone else. But for really serious injuries like pneumothorax, they just shouldn't happen if we're applying that level of clinical reasoning and essentially common sense overlaid on top of our understanding of anatomy and physiology for the person. And so that's why when I hear of people receiving pneumothorax from needling, acupuncture or dry needling, it sort of saddens me, because I think, well, not only does it give the rest of us a bad name, and muddy the perception around what this great modality is, but it shouldn't occur. When if we're applying good clinical reasoning, it shouldn't occur. Yeah.
Yeah, that's right. And we obviously there's rules to follow. There is elevated level of risk in that area, but yeah, it comes back to those fundamental skills of palpation, knowing your anatomy, applying good, safe dry needling technique, and then the risk of causing adverse events significantly decreases.
Yeah, definitely. I think we might have summed it nicely there, Bo. If anyone's got any doubt now about uh, the potential risks of dry needling, it really just comes down to skill and understanding of the body. Yeah, and anything could be dangerous. Any tool can be dangerous. Any human can be dangerous when it's not wielded or effectively used. And so dry needling does hold some inherent risk, but in the hands of somebody who knows what they're doing and knows the human body well, it can be a really effective tool.
Yeah, couldn't agree more.
Nice. Okay. Should we leave it there?
Yeah, thank you very much, Shaun.
Thank you. Thanks, bud. Talk to you
Cheers.
all again soon.